Welcome to The Explainer. Let's jump right in because today we are taking a notoriously dense, incredibly complex set of virology notes on the Filoviridae family. Yes, the viruses behind Ebola and Marburg, and we're transforming them into your ultimate survival and study guide. If you're prepping for high-level board exams, or honestly, if you're just a focused learner who wants the actual science without all the Hollywood sensationalism, you are in exactly the right place. We're going to break down the virology, bust some massive myths, and give you the absolute high-yield facts you need to know. So here's our game plan for this explainer. 1. Meet the Filoviridae. 2. Ebola versus Marburg. 3. Transmission and exam traps. 4. The clinical phases. And finally 5. Diagnostics and treatment trials. Let's get to it. Section 1. Meet the Filoviridae. The basics of a BSL-4 threat. Okay, physically, this virus is just fascinating. Filoviridae literally gets its name from its filamentous structure. It looks like this long, tangled thread, or sometimes it loops into a bizarre 6 shape. It is a completely unique look among human viruses. Genetically, we're looking at a linear, non-segmented, negative-sense RNA virus. But here is the absolute most critical takeaway. These are WHO risk group 4 pathogens, meaning handling the live virus requires a biosafety level 4 or BSL-4 laboratory. We're talking full-body positive pressure suits and absolute maximum containment. To really grasp how this virus attacks, we have to open up its toolkit. It has 7 main structural proteins, but you really only need to lock in on 3 key players. First up is GP12. This is the glycoprotein spike right on the surface. It acts like a key, determining what cells the virus can infect by binding to a very specific receptor inside our cells called MPC1. Then, you have the ultimate immune evasion villains, VP35 and VP24. These 2 proteins are remarkably good at suppressing your body's type 1 interferon response. They essentially blindfold your innate immune system, letting the virus replicate to staggeringly high levels before your body even realizes it's under attack. Section 2. Ebola versus Marburg. Spotting the epidemiological clues. Now, pay super close attention here, especially if you're taking medical boards anytime soon. You have to be able to separate these 2. Think about the environment and those early index cases. Ebola. That's typically tied to humid rainforests, where outbreaks usually trace back to a single index patient, often linked to handling bushmeat. Marburg, on the other hand, lives in arid woodlands, and more specifically, caves and mines. If you're reading an epidemiological report and it mentions someone exploring a cave or working in a mine in equatorial Africa, alarm bells should be ringing for Marburg. And this brilliantly illustrates one of the biggest exam traps out there. It is so easy to assume that bats are the proven reservoir for all filoviruses. But actually, for Ebola, the animal reservoir remains officially unknown. Yes, bats are strongly suspected, but it is not definitively proven. However, for Marburg, the reservoir is confirmed. It is absolutely the Egyptian russet bat. Keeping that distinction crystal clear is pure high-yield gold. Section 3. Transmission and exam traps. Busting Hollywood myths. I want to pose this question directly to you, because movies like Outbreak have totally skewed how we think about this. Is Ebola airborne in natural settings? Just think about that for a second. The answer is a definitive, hard no. There is absolutely zero aerosol or respiratory droplet transmission in natural settings. It's just not contagious the way measles or the flu is. Because of that, standard contact and droplet PPE, gloves, gowns, face shields, that's entirely sufficient for basic barrier nursing. You literally only need an N95 mask if you're doing a specific aerosol-generating medical procedure. So, how does it spread so violently? Direct contact with infectious body fluids. Tragically, traditional burial practices, specifically the ritual washing of corpses, are massive outbreak drivers because dead bodies remain highly, highly infectious. The viral load actually peaks right at the time of death. And get this, the transmission risk doesn't just vanish the second a patient survives. 12 months. That is the minimum recommended time survivors have to abstain from unprotected sex or wait until they get a confirmed negative PCR test. Why? Because the virus literally hides out in immune-privileged sites in the body, most notably in semen, long after the patient has clinically recovered and their blood is totally clear. Section 4. The clinical phases. Mapping the pathogenesis timeline. Let's walk through exactly how this plays out in the body. It starts with an incubation period of 2 to 25 days. And here is a huge takeaway. Patients are not infectious during incubation. They only become contagious the moment symptoms start. Phase 1 is an influenza-like prodrome. It hits hard and fast with fever, chills, and severe headache. But days 5 through 7, that's when things take a terrifying turn into the multi-organ phase. The virus targets macrophages and dendritic cells, causing huge lymphocyte depletion. Endothelial dysfunction makes the blood vessels leaky. Patients get hit with profuse watery diarrhea and vomiting, which leads to massive fluid and electrolyte loss. Okay, pause. Here is a crucial exam trap. Forget the movies where everyone is bleeding from their eyes. Hemorrhage is actually not the predominant feature of filovirus disease. Sure, it happens in some patients because platelets stop and clotting factors are lost, but it's not the main event. The true mechanisms of death, which usually happen between days 4 and 14, are severe hypovolemic shock from all that fluid loss, followed by multi-organ failure. If you're looking at the labs for someone in that multi-organ phase, here's the story the numbers will tell you. First, you'll see AST levels significantly higher than ALT. This is incredibly characteristic. It happens because the virus causes severe hepatic necrosis, basically destroying the liver's Kupffer cells. You'll also see severe leukopenia, white blood cells just tanking due to lymphocyte depletion in the spleen and lymph nodes. Platelets drop, causing thrombocytopenia. Coagulation times like PT and PDT become prolonged. And of course, you've got massive electrolyte derangements from the severe diarrhea. Section 5. Diagnostics and treatment trials. The path to survival. So how do we actually lock down a diagnosis? The gold standard is the RT-PCR assay. Now, rapid antigen tests do exist, but their sensitivity isn't great, so they're mostly used post-mortem. For living patients, finding that viral RNA via RT-PCR in acute blood or serum is the definitive answer. And what's really incredible is that we now have field-deployable PCR platforms, like the GeneXpert. These can be carried right into the epicenter of an outbreak to give highly accurate, rapid results. Which brings us to a real game-changer in virology, the PALM trial. This was an absolutely historic moment in medicine. Conducted during the massive 2018 to 2020 outbreak in the Democratic Republic of the Congo, the PALM trial was the very first randomized controlled trial for Ebola virus disease treatment. Think about that for a second. Human ingenuity managed to run a rigorous clinical trial right in the middle of a war-torn active outbreak zone. And that trial gave us 2 incredibly successful, fully FDA-approved treatments for Ebola. The first is a single monoclonal antibody called MBA114, or Ansuvimab. The second is REGN-EB3, which is a powerful 3-antibody cocktail. Both are given as a single IV infusion and are approved for everyone, adults, children, even pregnant women. They work by specifically targeting the Ebola virus glycoprotein. But listen closely, because here's the catch. These therapies are specific to the Zaire Ebola virus. There is currently no approved specific therapy for Marburg disease. For Marburg, we are still 100% reliant on aggressive supportive care. Alongside those targeted treatments, we also have a highly effective vaccine for Ebola, known as Ervebo. But honestly, it's not just the vaccine itself that's brilliant, it's how public health teams deploy it, using a strategy called ring vaccination. Instead of trying to mass vaccinate an entire country, they identify a confirmed case and they immediately vaccinate all their close contacts, plus the contacts of those contacts. It literally builds a protective ring of immunity around the patient, starving the virus of new hosts and stopping the chain of transmission dead in its tracks. Which brings us to one final heavy thought. We've got better tools than ever before. Rapid PCRs, monoclonal antibodies, ring vaccination. But filoviruses, they are incredibly resilient. Consider this. The 2021 outbreak in Guinea was genetically linked to a survivor from the massive 2013 to 2016 outbreak. That means the virus hid in a survivor's body for 5 to 7 years before sparking a brand new chain of transmission. With the very real threat of long-term viral persistence, how will global health systems adapt to respectfully monitor survivors and prevent the next major spillover? It's a massive, critical challenge for the next generation of experts. Thank you so much for joining me for this explainer. Keep reviewing these notes, stay focused, and I'll catch you next time.